Well, thank you very much for having me. This is a lovely venue for you all to have a conference in. And so I thank you for coming out so early in the morning and also for actually being inside instead of out playing golf or doing something fun on the beach. So the whole topic about Zika and pregnancy really suddenly came upon our radar just a few years ago with much publicized increase in the incidence of fetal and neonatal effects in Brazil, particularly microcephaly. As we're such a mobile society, it soon became a problem for those of us in the United States as well, and soon became a public health crisis worldwide. We're very lucky at Hopkins in that we have Dr. Jean Sheffield as our division director, and Jean also sits on the advisory board for the CDC. She's an infectious disease and pregnancy specialist, and she's been working very closely with the Zika guidelines and all the advisory updates. Hence, I think I drove Lee probably crazy because Jean kept telling me that about every 2 weeks, oh, you have to update this, you have to update this on the slide. So hopefully we have the most up-to-date information unless something came out in the last couple weeks. So I have no financial conflicts related to this presentation. By participating in the session today, we hope that you'll be able to describe the methods of transmission of Zika following the discussion, be able to educate your patients effectively in the prevention of Zika infection, and identify resources with the most up-to-date protocols for screening and appropriate management of pregnant women or those who are thinking about becoming pregnant with respect to Zika infection. And probably that third objective is the most important in knowing where to find this information, since as I illustrated, it keeps changing on us ever so slightly. So to give you a little bit of background, our first travel, first of all, many of these reports were identified through the yellow fever surveillance program, because a lot of these arboviruses are overlapping in terms of regions of the world and risk. In 1947, the Zika virus was first identified in the rhesus monkey in Uganda. In the 1950s, the first human case was reported. There were some small-scale epidemics, again, found through the yellow fever monitoring in North Africa and Southeast Asia. And in 2007, so a long time later actually, they found that 73% of the population in Micronesia was actually infected. From here, it spread to the Pacific Islands and also to the Americas, where you begin to see historically some rare reports of fetal effects. And then that brings us up to 2015, when Brazil reported a Zika outbreak along with the dengue outbreak. So the dengue virus is another arbovirus, and these two often go hand in hand because their vector is the same. And in this case, there were lots of increased reports of microcephaly in the area of Zika and dengue. And this is what you began to see in the news. So if you look at the global spread of Zika, you can see that it's very obvious that where the cases of Zika infection, particularly microcephaly and other birth defects, are seen, it follows the pattern of the Aedes aegypti mosquito, which is the common vector. I can't believe I even spit that out. I went on Google to try to figure out how to say that multiple times. Most humans, thankfully, are asymptomatic or have mild flu-like illnesses, but these are similar to a lot of the viral illnesses, so nobody really has it at the top of their mind, oh, I've got Zika infection. And that includes pregnant mothers. The other thing that's important to know, and particularly for those of us here in the United States, I mentioned what a mobile society we are. And one of the studies published last year in the Lancet showed the anticipated international spread of Zika from Brazil up through the Americas. And you can see the speculated widespread distribution of where Zika might show up because of the rate of air travel. So kind of scary. This means, especially in the Southeast here, that we are not immune to having to screen our patients who are traveling and look for possible Zika infection. So because of the frequency of the cases that were reported, In 2016 and into 2017 now, in January of 2016, the CDC began its Emergency Operations Center, and it raised their level of concern to a level 1, which is the highest concern. This means that lots of resources go into this division to follow the reports, develop strategies for prevention, keep the advisories up to date, and look to see why it is or what are some of the mechanisms, the research mechanisms, and how Zika is causing birth defects, is causing infection, and also Guillain-Barré, which we're seeing in adults as well. In February, following the CDC upgrade to emergency operations, the WHO also declared a public health emergency of international concern. And again, because you can see in this diagram here, where there were clusters of microcephaly and other neurologic disorders that were caused by Zika. So not just in fetuses, but adults as well, particularly in the form of Guillain-Barré. So in the US, there were a couple of pockets where there were documented transmission cases of Zika, particularly among pregnant women. And those were in the Brownsville, Texas area and the Miami-Dade County area. And to this day, the CDC still has a travel advisory for the Brownsville area. However, the CDC has lifted in June, this is one of the reasons this presentation kept changing. In June, the travel advisory was lifted from the Miami-Dade County area, and that's because for, I think it's 5 months, I gotta remember what the standard is, but for a period of time, there were no cases of Zika reported or transmission of Zika, or any cases that were under investigation. So it has to be both. No reported confirmed infections and no cases that are under investigation. So that travel advisory has been lifted. The other thing that's really important to note when you look at these CDC websites is there are 2 categories. There's the CDC areas of concern that contain travel advisories, because those are areas where there have been documented transmission. And then there are areas of concern where the possibility exists, but they don't have, because potentially they have mosquitoes they've identified carrying the Zika virus, but they don't have any documented cases or cases under investigation yet. So we have to be very careful when we look at those sites and explain that to our patients, that we understand which those are. The CDC also set up a U.S. Zika pregnancy registry. And if you look at the cumulative cases from January through December of 2016, you can see that the cases markedly increased from April to January of last year. And this is the total number of pregnancies reported in the 50 U.S. states and also in the District of Columbia. So I live near D.C., political commentary. They can't stand being listed as the other on there. They want to be a state. So every time they see this and we do talks there's always comments from the audience or a little buttering in the background there. So CDC and Zika, again, what is the CDC doing about this now that this has become a public health crisis? Well, number one, as I mentioned, they set up an emergency operations center and they raised it to a level 1. That's the level with the most resources put into working on this crisis. They are posting continuous travel guidance, and these are updated about every 2 to 3 weeks, the travel guidances, again, based upon documented, proven Zika infections and transmissions. They're monitoring infections among pregnant women to identify the consequences of congenital Zika infection. I'm going to go into that a little bit more in detail soon. They're working with clinical experts and organizations around the world, actually, to update this guidance. They're researching factors that might affect birth defects in fetuses, and we'll talk a little bit also about some of that research that's going on that maybe I'm just a nerd, but I find really fascinating that they can do this. And then they're trying to improve laboratory testing. This has been a big problem because of, number one, the duration of viremia, and the fact that we did not know what that duration was to start with. And that seems to be evolving as well. And also, if you're testing for the IgM, the immunoglobulin for Zika, it cross-reacts with the dengue virus and some of the other arboviruses. So they had developed mechanisms to be able to sort that out as well. And then they are continually publishing and establishing guidelines in terms of prevention, in terms of protection, travel advisories, treatment, that sort of thing. Okay, so that's a little bit of the background. Let's look now at Zika transmission. So there are really four main ways that Zika can be transmitted: through mosquito bites, through vertical transmission during pregnancy, sexually exposed being sexually exposed to the infected individual, and blood transfusion. So that's really important as well. Interestingly, while they can find some of the viral RNA in breast milk, there are actually no reported cases of transmission during breastfeeding or through airborne droplets. So let's take the first one, that's transmission from mosquito bites to begin with. So once an individual has been bitten by a mosquito that's carrying the Zika virus, the incubation period is about 3 to 12 days. Then once the incubation period is over and the person has a frank viremia, they may or may not actually have symptoms. They may not realize they've been infected and have the Zika infection at all, because only about 1/5 of infected individuals are affected by the development of symptoms. So this too makes it very difficult for us to identify those individuals. Some of the major symptoms include acute onset of fever, maculopapular rash, arthralgias, and conjunctivitis. Occasionally there will be myalgias, headaches, retroorbital pain, pruritus, vomiting. This sounds like any other viral infection you get, so there's nothing really that makes it stand out. Most of the time these symptoms will last up to about 7 days. So very rarely does this cause a severe disease. Not surprising, given only about 20% are even affected at all. It does, however, they're seeing an increase in incidence in these areas of concern for Zika, where there are documented transmissions. They're seeing an increase in Guillain-Barré. Well, we all know, even though we don't completely understand the mechanism, that Guillain-Barré can follow, particularly in adults, viral infections. So it's not surprising that this virus as well could cause that, especially since it seems to have a propensity for neural cells. In addition to that, it can cause pregnancy complications, and while this is under adults' disease sequelae, we'll go into this a little bit more. The interesting thing, and I think important thing to know in counseling your patients, is that past infection. So let's say the woman had a past infection with Zika when she wasn't pregnant, that is not linked to future pregnancy complications. So I think that's really important for the patient to understand. And that's if the virus is cleared, and you can do a test to make sure that the virus is cleared. So the first one was mosquito transmission. Now let's look at vertical transmission. So vertical transmission from the mother to the baby can happen antepartum, so anytime during the pregnancy, intrapartum during delivery, but not, at least not at this time, known during breastfeeding. So breastfeeding is not contraindicated in these mothers, and that's really, really important. So no cases, even though the Zika RNA has been identified in the breast milk, there are no cases of fetal infection following breastfeeding. What about the effect of pregnancy and disease and transmission? So there are a lot of unknowns here, actually. John, can I move your phone down underneath you? Thank you. So there are a lot of unknowns, actually, with the effect. And so this is where it gets a little dicey, counseling our pregnant patients. So it's unknown if pregnant women are more susceptible. The disease does not appear to be any worse in pregnancy. However, transmission is seen to occur in all trimesters. And as you'll see by some of the data, it appears that while the disease is transmitted less often, very similar to rubella and cytomegalovirus, or CMV, while it is transmitted in the first trimester, although not as frequently as the second or third trimester, that first trimester infection, if it is vertically transmitted, appears to have more devastating effects. So there are several case reports. Let's move on to sexual transmission. So this is the third method of transmission. There are several case reports beginning in 2015 with Musso's report of potential sexual transmission. It was again confirmed in Colorado and then in Texas. All of these cases appear to be male to female. And there are several new cases that are also being investigated currently in late 2016 and early 2017. The reason we think that it's male to female is that there seems to be longer carriage of the virus, particularly in male semen, than there is in any vaginal fluids or in the blood. So since Zika can be passed through sex from a person who has sex with Zika partners, it is recommended that women who are having sex with partners who have the Zika infection or were exposed to Zika wait at least 8 weeks before having intercourse with that partner, or if the woman is infected, I'm sorry, and if the male is infected, they actually recommend waiting 6 months, so a much longer period of time because it seems to clear faster from the woman. Condoms can reduce the risk, but it's not 100%. And the fourth method of transmission I mentioned is by blood. So if you have traveled to an area where mosquitoes are actively spreading Zika in the past 3 months, you are not eligible to donate blood in the United States. And this is actually, while it's an FDA guidance, it's actually a WHO guidance as well. You also do not donate blood if you've had sexual contact with a person who traveled to live or lived in an area where there's active spread of the Zika infection in the prior 3 months. As well, you would not donate blood if symptoms concerning for Zika have occurred within the last 4 weeks and you have been traveling or come in contact with persons traveling to those areas. So pretty strict instructions in terms of when you cannot give blood with exposure to Zika. So here comes the really tough part that the CDC and researchers have been dealing with, and that's how to really test for Zika and have some certainty as to whether the patient is infected or not. So let's start with pregnant patients and screening. This is really, really important that we screen our pregnant patients, and actually at every single visit. So, for example, in our prenatal clinics, high risk, low risk, any clinic, and of course in the Baltimore, Washington area, it's a very mobile area there where people are coming in from all over the world. So we don't discriminate on somebody who lives in Baltimore and has never gotten on a plane. Everybody gets screened every single time they come in for a prenatal visit. And we ask them 3 questions that basically line up with the 3 that you see here on the screen. And our current questions, and again, we're updating these on a monthly basis too, because you can bet Dr. Sheffield makes sure that we're asking for the right areas. The first question we're currently asking is, have you or your partner traveled to Brownsville, Texas since October of 2016? Have you or your partner traveled to South Florida or Miami-Dade County since June 2016? Now I suspect since that just changed in another month, she tries to lag about a month or so behind when there's a change in the advisory in terms of taking something off, not adding on, but taking off. The third question is, have you traveled to, and here's a long list, Central America, South America, Pacific Islands, Caribbean, or Cape Verde since you've been pregnant, or for 8 weeks before you became pregnant? Or have you traveled to Brunei, Burma, Cambodia, Indonesia, Laos, Malaysia, the Maldives, Philippines, Thailand, Timor-Leste, or Vietnam? Huge list. So again, our nurses are screening all the patients when they came in. And then the final question is, has your partner traveled to any of the above mentioned locations since you've been pregnant or for 6 months prior to you becoming pregnant? If any of those questions are yes, then we move to testing. It's a good thing the nurses do a lot of the screening. I'd never have time in 15 minutes to go through all of these. So then who should you test? Okay, so that was the next big question. So first of all, anyone with recent Zika symptoms, that's a no-brainer. All pregnant women, regardless of symptoms, who either live in or recently traveled to an area with risk per the CDC, because remember there's an area with risk per the CDC and there's an area with concern but not on the CDC advisory list. And certainly if they had unprotected sex with a partner who traveled to those areas. And then finally, pregnant women who live in or recently traveled to an area with risk of Zika but without a CDC notice. Those we do if they're symptomatic, or if we find in screening that the fetus has abnormalities on ultrasound. I will tell you that last one's a little squishy. I got that word from Joan because we were talking about squishy recommendations on other things from ACOG yesterday. So a little squishy because if your patients went to an area that they see is of concern but doesn't have an advisory, do you think they're going to take no for an answer on testing? Unlikely. So we will be a little bit squishy as to whether we decide to offer them testing or concede to testing if they're asking for it because they're concerned about exposure. The other thing we can offer them as well is the serial ultrasound screening of the fetus. The important thing here also is that if you're getting testing, so not all labs can do the sequential testing that's necessary. We need to test for the viral RNA by PCR, polymerase chain reaction testing. We also need, because that's cleared eventually, we also need to be able to test for IgM, so the immunoglobulin, but that's going to lag behind the viremia in most cases. There may be some overlap, but it lags behind. So you could be testing a few weeks after the viremia has already cleared, and that PCR for the viral RNA is going to be negative, but the patient may still have been infected or have vertical transmission to her fetus in the case of a pregnant patient. So you want to make sure that you get that IgM at the same time for Zika. In addition to that, I mentioned earlier that there's cross-reactivity between those immunoglobulins and other arboviruses like dengue. So then it's necessary to do a third test that can sort out whether these are antibodies specific to dengue, specific to Zika, or another arbovirus. So it really is a three-step process if you don't automatically get that viral DNA back as positive. It takes a long time. If you send this to a lab who only does PCR and then you wait a week or so, you get the results back, and then you have to send to a different lab for the subsequent testing. So it's important to look in your system where you practice what tests are the various labs doing. Preferably, they would have the capability to do all three of those tests because then it can be done in a more expedited manner and your patient's going to get an answer back a little bit more quickly. So again, the real-time PCR has been validated on serum, amniotic fluid, placenta, fetal tissues, and semen. It's good for about 7 days after the onset of symptoms. Theoretically, the virus clears after that, and your PCR would be negative, but that doesn't mean your patient hasn't been infected. So then we do the serologic testing, which turns positive about 4 to 7 days after the onset of symptoms. You need to do the plaque-producing neutralization tests in order to sort out whether it's Zika or dengue or another arbovirus. And then, for example, if you have tissues, let's say from a miscarriage or a placenta at the time of birth, you can actually do immunohistochemical staining and see the arboviruses in the tissue. Very, very important. Any of your patients who test positive at any of these tests for the Zika virus, this is a nationally notifiable disease. The easiest thing for you is to contact your local public health department because they'll bump it up to the national registry after that. And actually, your local public health department is probably the best place to contact to determine where you're going to send your testing samples as well. So what about asymptomatic pregnant women? So the first thing to do is risk for screening and exposures. And if they're asymptomatic, you would test them if they have a positive screen anyway, even if they're asymptomatic, or if they've had exposure to a partner with Zika. If the test is negative and you know that they've had a confirmed exposure to a confirmed infected individual, you might consider doing the immunoglobulin testing qtrimester, just because in some patients that immune system's going to lag behind. If the patient's having an amnio for another reason, you might be able to get an answer a little bit quicker by doing the test on the amniotic fluid. Typically, we don't do the amnios just for this reason, though. And then it's important when you're doing the testing qtrimester to make sure you keep reiterating the limitations on the IgM testing and the RNA testing later on. Preconception, you could consider doing a Zika virus baseline if you know someone's been exposed. However, that is not predictive in any way of whether or not the fetus is going to be affected. Oh, and one last thing. The newest recommendation is not just to get blood testing, but to send blood and urine at the same time, because they're finding that one or the other might be positive and the opposing specimen negative. So to be absolutely sure. The take-home message from all of this, and this is from a look at the Zika registry in April of this year. I'm sorry, in January of this year. And they looked at birth defects among fetuses and infants of U.S. women with evidence of possible Zika virus infection during pregnancy. And they found there was about a 6% incidence of infected women in the U.S. with evidence of birth defects, primarily microcephaly and other neural abnormalities, and 11% incidence of birth defects in women with first trimester infection. So again, this is the evidence it's building that first trimester, even though transmission seems to be less frequent, is more severe. Again, screen all pregnant women in the U.S. for exposure at every prenatal visit and at preconception visits as well. All right, so now let's move to the fetal evaluation. This is where all the devastating reports have come out in the news. I've listed for you here all the currently reported effects, congenital Zika effects. And many of these are interrelated in terms of the development of the brain. And we'll look at a case here that illustrates this. The congenital Zika syndrome is another term you might have heard of, and that's a pattern of birth defects. A severe microcephaly or small head size, and I'll define that for you in a moment, resulting in a partially collapsed skull. Remember, the skull in the fetus really is very soft still because it's not calcified yet, so if the brain tissue is not developing and exerting pressure, it is also going to collapse around that diminished neural tissue. Damage to the retina with specific pattern of scarring and increased pigment, so it's not just confined to the cortex, but also to the optic nerve and the retina. Joint contractures, this is thought to be due to effects on the nerves that keep the fetus moving its limbs, and then hypertonia restricting body movement soon after birth. So this definition of microcephaly is different depending upon which source you look at. What we've adopted here in the United States is the 2016 recommendation from the Society for Maternal Fetal Medicine. And that's that isolated microcephaly is when there is greater than or equal to 3 standard deviations below the mean in terms of the biparietal diameter and the head circumference for gestational age. Pathologic microcephaly, so again, it's a little squishy at 3 standard deviations below the mean, because 1, it might be due to other viral infections, and 2, it could be, a variation of normal. Not generally, but it's possible. Pathologic is considered greater than or equal to 5 standard deviations below the mean for gestational age. Again, we're very careful here. So when the patient starts to go beyond 2 standard deviations below the mean, we start looking serially and very carefully at the intracranial anatomy for those markers that we might be able to see on ultrasound, like calcifications, decreased gyral formation, ventriculomegaly, things that are possible to monitor on ultrasound. So this is looking at a case that was published by Milo in 2016 where they actually had some very good pictures of the fetal effects, both in ultrasound, and they had an autopsy specimen after termination of the pregnancy. And so what we're seeing here is intracranial calcifications, both in the posterior fossa around the edge of the cerebellum. You're seeing an abnormally formed vermis. It should go straight across there, but you can see it's hypoplastic. You can also see some of the calcifications in other parts of the brain as well by these small arrows. You can see dysgenesis of the corpus callosum in this area in the sagittal view, and also depicted by this widened area between the two cerebral hemispheres here. Normally they're opposed to one another. So evidence of brain atrophy there. You also, and it's harder to see in real time, you'd be able to tell this a little bit better, but normally you would see more pronounced gyri formation along the edges of the cortex, which you don't see here. And then the other thing you can see is as this is atrophying on this side, you can see calcifications here too. You can also see the cranium collapsing. So where they should come together on the sutures, this side is asymmetrical in terms of its effect on the brain atrophy, and the skull is collapsing around it. So in this case, this patient chose to terminate the pregnancy, but also consented to an autopsy, which for patients who choose to do that, the autopsy is very helpful in terms of public health and gaining information about the effects on these fetuses. They did indeed find prominent microcephaly. The whole brain weight was more than 4 standard deviations below average. There was a small cerebellum and brainstem as well. Complete agyrus, so no gyral formations in the cortex of the brain. Internal hydrocephalus, evidence of the calcifications. And then under immunohistochemical and electron microscopy, they were able to see the viral particles in the neural tissue, particularly in the cortex. And here you can see those. You can see the viral particles inside some of the neurons that are actually breaking up here. And this is under a little bit higher power. In the autopsy specimen, to correlate what you're seeing here in the ultrasound, the ventriculomegaly, you can see widening of the ventricles here. So this is a coronal slice through the brain. You can also see areas in here that are a little bit whiter from calcifications. The frontal horns are also dilated, particularly on this side. It's collapsed over here and posteriorly as well. And this is just a close-up picture of what the eye abnormalities would look like, including chorioretinal atrophy and focal pigmenting. So you can see some of the focal pigmentations here as well, the modeling. So this is where I said I was a nerd. I found this really interesting, and probably one of the reasons I stay in an academic institution, because my husband tells me all the time I'm a perennial student. So this way I get to go to all these talks all the time and pretend I'm still in school. So this research is not entirely confined to Johns Hopkins, however. I want to make sure that credit is due to others too, because similar work at looking at the mechanism of how Zika affects neural tissue and to help explain microcephaly are being done at Emory, at Florida State, Stanford, and others as well. But those are probably the big 4 that have started to publish their work and present their work. What they've done is they've taken pluripotential stem cells and they formed little mini brains. And it's very cool. It's almost like they have a little ice cube tray and they have these little mini brains growing in each of them. And they infect them with the Zika and then look at them with histochemical stains. And what they're finding is that the Zika seems to have a preference for neural progenitor cells that are destined to form cortical or cerebral cortical tissue. And what happens is that they cause apoptosis and then eventually atrophy of those little mini brains that are growing in there. And they cause a defect also in the migration of the neural cells to form the various parts of the brain. Very interesting work and also a very plausible explanation for how Zika is causing microcephaly. The next thing, obviously, is how to stop that. So they're working on, they're actually looking at, they have 3 drugs that are promising currently. They're still listed as X, Y, and Z when I looked at their website. But 3 drugs that are promising that might have some effect on stopping the Zika from attacking the neural progenitor cells. So what are the recommendations for fetal evaluation? So for women who have traveled to an endemic area, obviously the testing that we talked about before, but then taking a look at the fetus. So we ultrasound these women every 3 to 4 weeks after symptoms or after exposure. The first things we're generally able to see, obviously, are the intracranial calcifications, but also looking for microcephaly. Again, the microcephaly is caused by CMV, it's caused by rubella, it can be caused by certain genetic syndromes, both single gene and whole chromosome syndromes like trisomy 13 or 18. So you need to make sure you're ruling out those other things along the way. If mother's PCR or her immunoglobulins are positive for Zika or inconclusive, we continue to ultrasound every 3 to 4 weeks, looking for evidence, particularly neural evidence of Zika infection. If the ultrasound is abnormal or the maternal testing is positive for Zika, we offer an amniocentesis after 15 weeks to look, not to screen, but if there's already evidence that mother's infected or the fetus is infected. The problem is this is one of the I don't know, we don't know for sure, and that's that there's limited knowledge on how good the amniotic fluid PCR is at this point in time. So the take-home message in terms of fetal effects, again, this is looking from April now, an update on the U.S. registry for Zika infection, is that infants born to possible Zika-infected mothers should have, in addition to the serial ultrasounds and potential amnio during pregnancy, after birth, they should have postnatal neuroimaging and Zika viral testing, plus the usual newborn exam and hearing screening. And interestingly, when they looked at almost 1,300 pregnancies with possible Zika infection in the U.S., they found that 1 in 10 had associated birth defects, but only about 25% of infants were getting any follow-up neuroimaging after delivery, and only about 65% were getting any testing after delivery. So because these effects can sometimes be very subtle, but might help to inform neurodevelopmental abnormalities later on in childhood, it's important for this testing to occur. Again, in counseling the patient after your screening and deciding on testing, we don't know exactly what the incidence of actual infection is among pregnant women who are exposed. We don't know the actual rate of vertical transmission. We're just starting to get some of that data in. But we're going to miss, it's going to be underreported anyway because a lot of patients may not know that they had a mosquito bite or had a viral infection. We don't know the rate of the clinical manifestations if the fetus is infected, although there's some evidence that's now building that says that it could be more devastating if the fetus is infected in the first trimester than the second or third, but can be affected throughout the continuum of the pregnancy. However, we do know that if a woman was infected prior to pregnancy and greater than 4 weeks before conception, it is not expected that she'll have any fetal effects because of the clearing of the virus before then. So that is the one known that the CDC is willing to take a lead on the data. Treatment, just like any other viral infection, it's really supportive. The one thing you want to make sure that you don't do here is to treat with non-steroidals before you have ruled out whether this is Zika or dengue, because it could exacerbate the leading of a dengue virus infection. So no treatment with non-steroidals until you're sure it's not dengue. Prevention. Now we might say this is common sense. However, over and over again, we're getting messages from the CDC to impress this point with our patients. If you are in a Zika-infected area or where there are mosquitoes that carry Zika, make sure that outside you empty and clean water containers weekly, that you seal outside storage water containers where the mosquito can breed, that you put larvicides in any standing non-drinking water, and that you use insect sprays in mosquito areas and maintain septic tanks. The reason it probably hasn't spread as much in countries that are of higher socioeconomic status is because they have more public health measures to do this in place. Inside, if it's possible, they recommend, if you're in one of these areas, to keep the windows closed, use screens, use your air conditioning, or if that's not possible, to at least use a bed net, much like other infections that are carried by mosquitoes. Again, empty indoor standing water containers and clean them once a week and use indoor insect spray. A word about the personal insect repellents. So not all of the insect repellents are going to work for these mosquitoes that carry the Zika virus. So it's important to look on the CDC website and make sure that these are CDC approved insect repellents. And all of these that are listed up here, particularly D, are okay to use in pregnancy. They also recommend that if you're outdoors to keep the skin covered, and you can put permethrin on your clothes, do not use it on your skin. And then use repellent for 3 weeks after return so that a mosquito doesn't bite you if you've been infected and then carry it to somebody else. The CDC also recommends that you have a discussion with your patients who are considering traveling and that they can talk about this with you to postpone travel to areas with ongoing Zika virus transmission. And if they have to travel, then use the preventative methods that we talked about. Big thing. If you must travel, discuss with your physician and adhere to mosquito bite prevention. We have a sign in our prenatal clinic to remind people of this and to have that discussion with us. In terms of recommendation for sexual transmission, use condoms or not have sex with someone who's been infected or travel to a Zika travel notice area. For females, again, it's 8 weeks. For males, it's 6 months because, again, the virus is carried longer in semen than it is in blood or female vaginal fluid. And then finally, I want to close, since this may all change in 2 weeks, I want to close and make sure that you have access to all the websites that the CDC is working very hard to keep up to date. And that you are aware of the reporting guidelines. So again, healthcare providers must report cases to their local, state, or territorial health departments. These departments then feed any reported cases into ARBONET or cases that are under investigation. ARBONET is the National System for Arboviral Diseases and also to the U.S. Pregnancy Registry. And all of these are in the handouts that you received. Detailed testing guidelines, since they're constantly trying to improve testing methods, are listed on the CDC website. Updates for pregnant women are continually updated because of the devastating effects. Most recent case counts, so you can look within the U.S. itself and see where the most recent cases have been identified. Sexual transmission guidance is spelled out very clearly for us and for the layperson. The latest travel notices. Many of you may actually be getting these travel notices from your local health departments, and I hope that you are. And then ACOG, the American College of OB/GYN, has a very nice toolkit, as does the CDC, that they put together to help you take care of patients either preconceptionally or during pregnancy with regard to Zika virus, the Zika virus outbreak and counseling. So I hope we've covered most of these, and again, I think the last 3 slides are probably the most important take-home message with the ever-changing story of Zika viral infection.
Okay.
Questions? Okay, so the first question is, pregnant women traveling or living in areas at high risk for Zika exposure should consider all of the following to protect themselves from infection. A, use EPA registered mosquito repellents with at least 1 active ingredient such as DEET. And the Environmental Protection Agency registration, by the way, is also sanctioned by the CDC. B, empty and clean outside containers of standing water weekly. C, wear protective clothing covering clothing and skin with permethrin. And D, practice safe sex, which means abstain or use condoms. Which one of these is not appropriate?
It's not. It's, yeah.
Okay.
Yeah, do show of hands because it's not.
We brave and do a hand vote. How many say A is not correct? B, C, and D. Oh, and most of the group got this correct. It was C. Wear protective clothing covering clothing and skin with permethrin. You cover your clothing with permethrin. You do not put that on your skin, particularly if you're pregnant. Okay, the second question is, Zika viral infection is difficult to diagnose as the maternal signs and symptoms and fetal effects are similar to other viruses. The CDC has activated the Emergency Operations Center to level 1. Which of the following is not an action also being taken by the CDC? A, provide low-cost vaccines to the virus. B, posting frequent updates on travel guidance. C, researching factors that might affect birth defects in fetuses. And D, improving laboratory testing for Zika. And this one was even more unanimous, and that is that that the CDC is not providing low-cost vaccines. They're not providing any vaccines, low-cost or otherwise, at this point in time. All of that is, however, under investigation, and the government of the U.S. actually put a large pocket of money aside for testing for vaccines and furthering the research on Zika and Zika vaccines last fall. Question number 2, when counseling your patient who plans a South American vacation about the risks of Zika transmission, which of the following is not a documented transmission risk? A, vertical transmission during pregnancy. B, breastfeeding. C, sexual exposure to infected individual. And D, blood transfusion. Oh, this time everybody got this one right. Good, breastfeeding. This always worries me, actually, because oftentimes our default is going to be with various infections and drug exposures to say no breastfeeding. But in many cases, breastfeeding is still the preferred method and safe for babies. For example, in hepatitis is another more common example of that. Question number 4, a 30-year-old G1, so gravida 1, para 0, at 12 weeks of pregnancy, just returned from visiting family in the Brownsville, Texas area. She reports several mosquito bites noted during the visit. You will A, counsel her not to worry as the CDC travel advisory has been lifted from Brownsville. B, counsel her that more than 50% of those infected have symptoms and she'll be tested only if she becomes symptomatic. C, counsel her that she's early in pregnancy so her fetus will not be infected. Or D, counsel her to receive blood and urine testing for the Zika virus. Oh, good. And the answer is D, you are going to test this patient because it was Miami-Dade County that was lifted, not Brownsville. Only 20% have symptoms, and we do know that while transmission seems to be at a lower rate, it has more devastating effects in early pregnancy. And finally, in the U.S., screening for Zika virus is recommended for all the following pregnant women except A, pregnant women with current or recent residence in a CDC-designated Zika area. B, pregnant women with recent travel to a CDC-designated Zika area. C, pregnant women presenting for a new OB visit as a routine screening lab. Or D, pregnant women having unprotected sex with a person residing in or who has traveled to the Zika area. So you're looking for screening recommended for all except, and almost everybody got this one correct also. C is the correct answer, pregnant women presenting for a new OB visit as a routine screening lab. So we are not going to do routine labs on everybody. They have to meet criteria from your verbal screening first. Okay, that's all 5 of those questions. Any questions from the audience? I don't know how much time I have left, Joe. Okay. If not, you get a little bit of a break, maybe? Oh.
Does insurance cover this and how expensive is it?
So I never say 100% for insurance these days because they're so variable, but I haven't had anybody that had a positive, said yes to any of the screening questions turned down currently. And in Baltimore, we have a gazillion different insurances feeding into our area. Yes, ma'am?
The IgM testing is good for about 12 weeks after exposure. We keep running into situations where we have women who would have been in the window to be infected when they got pregnant, but by the time we see them, they're outside of that 12-week window. So we can't really test them, or if they're actively infected, will it stay positive?
So interestingly, there are a couple of new reports of either the viral RNA or the IgM being positive in men, and the virus RNA being positive in men up to 60 days or so, which is unusual. So that's a little bit beyond or right around that 12 weeks from the onset of symptoms. And in pregnant women, we've seen it up to 120 days, or a couple of case reports. So we're still offering the testing.
And if the testing is negative because you're outside that window, are you doing serial ultrasounds?
Yes.
Okay.
Yes.
Thank you.
So the question was, if the testing is negative because you're outside what the theoretical window is for positive IgM, are you still doing the ultrasound screening? And the answer is yes. This year they're nice, they're passing the box around. Last year I had to throw it out to you.
You mentioned IgG testing, there's no role for that if it's outside that longer window.
Right, the IgM testing is what they're looking for acute infection, right? There's no recommendation for IgG at this point in time. And it may be because they have not developed the test to be able to sort out those antibodies from other noroviruses.